February 13th here. Rich, how you doing in Texas?
Doing good, man.
All
I got
right.
my Valentine's card from my wife. Did you get yours?
Sitting right here. I'll be filling it out when we're finished, probably. Hope everyone's doing great. Tonight we're going to talk about 5 devices that Rich and I use on the vast majority of our patients. And we'll go through each of these devices and talk about where they shine and where they don't shine as much. You know, a lot of you have heard us before, but a lot of times these webinars have new people on, so we kind of like to start with a little bit about dental sleep to make everyone who, in case you don't know, understand how prevalent and important it is to be involved in this. One thing we're all trained in dental school to do is screen for oral cancer. I mean, I think I was doing oral cancer screening, Rich, in first or second year. You know, they taught us this, how important this was, and every patient that we saw and every patient I've seen since, we try to do our oral cancer screening, which is important because people can have serious problems. But really, what are we accomplishing here when you really consider what's the prevalence? 1.001% of the people. I mean, how many oral cancers do people find? And when we give these lectures, Rich and I, we usually ask, you know, how many people found more than one oral cancer in the last 6 months? More than 2, more than 3. The most I've ever seen is 6 in a year that anyone's found in their practices after lecturing to tens of thousands of people. 1 in 5 adults. So look, you got 5 adults in your practice, 1 of them is going to have obstructive sleep apnea. 1 in 5. I mean, I think that number is even getting closer, wouldn't you say, Rich, from some of the newer information, to 1 in 4 even. So it's not going the other way.
No, it's not. And that's because we're all getting fatter for sure. You know, it probably depends on what part of the country you live in and how old your population. We know that Florida has a little bit older population, at least half the year, right, Guy? Right. So your sleep apnea rate in Florida doubles from what? December to March?
Yeah, it does, because we have a lot of, you can tell by the traffic out here and the speed at which it's moving. It's about 50% below the posted speed limit, no matter if there's 1 person or 100 on the road. But that's a different subject. 10% of the people who have obstructive sleep apnea, and maybe 15%, but 10% is pretty much accepted number, know they have it. So, I mean, you know, 9 out of 10 don't even know they have this problem. And once they know they have this problem, as little as 1 to 2% are really successfully treated. When I say that, we mean that most every night, most all night long, their airway stays open and that they're not having apneic events. So it's just a huge problem. Over 400, over 4 billion rather, a year are spent on CPAP. And, you know, a lot of times CPAP's not successful because they don't wear it. And Rich and I have been talking about dental sleep. We've been involved in it each for pushing 20 years each now. And we remember when this standard came out in 2006, which we kind of say changed the way we do things. That prior to 2006, it was even more challenging than it is now. Medical insurances didn't pay for dental devices. Physicians would slam the doors on us much more often. And when we try to say, let's use a dental device, they would say, well, no, that's not the standard. But in 2006, what do you say, Rich? It's the day the ground shook for dental sleep medicine or something, I think?
Yeah, it's hard to believe that was more than more than a decade ago now, Guy. But, you know, absolutely. I mean, those of us who started this many, many years ago know it was a little bit harder then. It's like you talking to your son, Guy, saying, man, you don't know how easy you have it. We do have it easier today, and part of that is because of these practice parameters that have come out. They updated these again, you know, in 2015. But we need to remember that, you know, we can do this, we should be doing this, and we're starting to get the support of a much broader base of not only physicians, but the public as well, and supporting what we do.
Absolutely. We will be doing another webinar. We do these every few weeks, so February 27th. This is, you know, we repeat some of these because there's a demand. The one we're doing tonight is one of the highest asked for, so we do it once or twice a year. But we're going to talk about documentation because that's one of the key, I would say, hurdles and challenges for dentists, because that's important. not only for tracking your patient success and communicating with physicians, but medically, legally. So we'll go through ways to make this paperwork much easier to manage and how we can do that. So I think we've already.
And why it's important too, Guy. You know,
Right.
because you can get audited when you do this, and I have been audited, and it's not that big a deal if you just document it, and it doesn't take that much time, but you have to know what to put down. So I'm the guy with less hair. Guy, you got to update that picture, man. You look a little bit younger in that picture, but anyway, we're glad you're here with us tonight, and we're gonna get going with these devices.
Yeah, suffice it to say, we've been doing this for 30-something years between the two of us. We do I've done thousands of devices. We don't know everything, but we know a few things, and we'd love to share that with you as well. I mean, we do these webinars, you can get a lot from it, but when we do hands-on courses, I would say as close to 100% of the attendees as you can come up and thank us afterwards saying, wow, I got a lot out of this. It's just a lot better to do a hands-on experience where you actually have these devices in your hands. We show you how to adjust them. We actually have a sleep test that you get to use the night between the first and the second night of the course of these 2-day courses, and we show you how to make adjustments, fit the devices, and it's a lot different than what you can get on a webinar. Our courses, including a device home sleep test for two days of CE, are at $1,000. But if you type in course tonight, you'll get even $200 off that. So let us know which of those towns or cities might be best for you. If you don't see a place listed there, we're always adding to. And I don't even know why we have this slide in here, Rich. I think we're pretty much sold out. But you're coming down when? Thursday, right?
Yeah, looking forward to that. Our second year for putting on the North American Dental Sleep Medicine Symposium. And I think we have about 20 speakers, so we only have a few seats left. But, you know, it's a great, we really concentrate on things that you can do to implement this in your practice. We're much more focused on the practical types of things. And, you know, it's last minute. We'll try to make room for you for sure.
Yeah, and you will get a CE certificate for attending the webinar tonight. You'll have it within the next 48 hours. If you don't see it, check in your spam folder. If you can't find it then feel free to contact us. But you will see the CE certificate arrive. And we, talk about success in dental sleep is as simple and as complicated, depending on how you look at it, at finding systems to screen, test, treat, and bill your patients. And the key to each of these is having a system in place so that you can walk through these steps. And used to, it would take me 2 to 3 hours to treat a patient in my time because we didn't have efficient systems. And if you have efficient systems to walk you through each of these steps, you can do it in under an hour of the doctor's time. Later on, we'll talk a little bit more about how we can help. But if you're interested in learning more about dental sleep and just actually getting in and doing this, we help dentists and dentist offices succeed and treat patients for dental sleep. We help through education, coaching, software, and support. If you have some challenges in your office and you want to just talk to one of our coaches, just type in consult, and we'll be happy to schedule a time with one of our trainers to meet and just answer your specific questions. If it has to do with dental devices or it has to do with medical billing or consultations, we'll be happy to take some time and help you with your challenges. So just type in consult anytime tonight. So let's get to the treating. Today in particular, we're going to talk about how we solve this problem right here. And I don't know if Dr. Moses is on, but I think he gave me that slide years ago. But I love this slide because I'm just going to do it again, Rich, because boy,
yeah, watch the tongue there. You know, that big old muscle there, big as a tennis ball.
It's a simple problem, isn't it? It's just a blockage back there. It's just a simple thing when we think about it, but boy, it causes a lot of problems. And so how we pull that jaw forward, how we tense up these muscles and tendons here, maybe it doesn't matter as far as how well these work in most times, but it certainly might matter how well they hold up and which ones are more comfortable, and that's what we're going to get through tonight. I think one thing I'd like to emphasize, this was done with MRIs on sedated patients, and on the left side of the screen you have the before protrusion. On the right, the mandible was actually protruded while the patients were sedated, and so that their airways were more collapsed. And I think the thing that was always amazing to me about this slide, Rich, was how much wider the airway is after you protrude. The blue is the airway here. I mean, it's bigger anterior posterior as well, but it three-dimensionally widens the airway when we pull the jaw forward. And so,
yeah, intuitively, that doesn't really make sense, does it? You think we're pulling the jaw forward, we would get better front to back, but interestingly, we actually get bigger side to side. But the bottom line is, for most patients, when we grab a hold of their jaw and we move it forward a little bit, we are opening their airway. It's just a matter of how much. And like Guy said, you know, the devices we're going to talk about tonight, are there other devices out there? Absolutely there are. Are there a lot of other really good devices out there? Absolutely. We just want to try to keep it simple at this point. We want to try to give you stuff that you can go back to your office and you can start doing this as soon as you can. That's what we're about. We want to get you started with this. We want to get you doing it, and we want to get you paid doing it so that you'll do more of it and help more people.
Absolutely. All right. So which device works best for you? Well, we have a method that works. We say 99% of your patients can be treated with these devices. I'd say it works close to 99% of the time, or maybe 98, 95. I don't know. This way right here. We have a dartboard up in our lab, and we just take a picture of each one of the devices, and you throw the dartboard on it. And so that'll end our CE course for the evening. You can, no, I'm kidding. We joke about this, and those of you who've heard us talk know this, that we say this often, but it's not that important which device we do to move the jaw forward until it's important. I mean, if the patient can't wear it, or if the patient's going to break it, I mean, they do the same thing. And what do you say, Rich? You have a good way of saying that. I forgot. You say it's you can't make a wrong, do you?
Yeah, I like to teach, Guy, that you can't make a wrong device, but you can make a better device.
There you go.
You know, yeah. So like Guy said, it's a little bit like insurance. You know, I mean, if your jaw hurts, maybe you made the wrong one or something. But that's why we're here to talk about this stuff. And
absolutely. So we're going to talk about the specific devices, and then as we go through these, we'll talk about why we feel that they're a particular device, that what cases they may work in better or not. Rich and I both believe that if you're going to do a lot of this and you're going to be helping your patients, that you should become a Medicare provider. We've done a lot of billing webinars, and we can explain why that is, but don't be afraid of Medicare. Medicare is a good for being involved, especially for the dental devices that we do. And so if we do become Medicare providers, then we don't need a dartboard. We just need a coin to figure out, because there's really two devices that we stick with, I would say almost always, between one of these two devices if they're Medicare. And that's the Herps, and there's and the TAP. And there's different iterations of both of these, but we're going to pick one of these two devices if it's a Medicare patient. The Herps, Rich, I know you and Keith Thornton are pretty close, and you do a lot of taps. I might do more Herps than you. So
I don't know, Guy. I'm catching up with you, but
okay.
You know, we like the Herps. You know, it goes back a long time when they started grabbing jaws and trying to grow them in little kids. So certainly, if you're an orthodontist, it's no surprise to you. But as we get older, our airways can still close down. So there's different ways of doing it. You got to grab onto the top teeth, you got to grab on the bottom teeth, and then we're going to reposition the jaw. So you got a couple of pictures of different ones, like Guy said there. These come in different iterations, different labs make them. If you don't have a favorite lab, you should call us and we can talk to you about who we like to use and that kind of stuff. But you can make this out of a lot of metal there, as you see on that one particular instance, Guy. And but it's a great device, and it holds up well, and it's tried and true, and it's been tested, and it's been used in hundreds of thousands of patients, I'm guessing. So it's hard to go wrong with it.
Yeah, let me describe it a little bit. By the way, I see some questions coming in. Our team's answering a lot of them. I know Rich answers some as we're going along, and we will get to all your questions, and we'll even stay on afterwards. We have several hundred people registered tonight, so we can't open up the mics, but we will get to your questions. So type them in, and we'll be happy to address them. The way this particular device works, just so that anybody that's new to this, is you put an instrument right here into this little hole, and then you turn it towards this plus. Or if you have this device, you would turn it towards a plus or this arrow, which makes it a little easier to see. And as you turn those screws towards a plus, it moves this piston back, which moves the jaw forward. And I would say one of the negatives to this is you've got to do it on both sides, which seems pretty easy until you live in Florida and you have a population, an average age of 100 and something, and they forget to do it. They get one side messed up. So you got to make sure they do it on both sides to do this. And the advantage to this, in a lot of ways, is your mouth can open. You can, me personally, I wear a dental device, and because I have little nasal problems, I can breathe through my mouth a little bit better. It's not as claustrophobic, and it doesn't have to fit that tight as well in some ways. But as Rich mentioned, there's different iterations. A lot of different companies make these from. Whole U, I think it's this one on the right, where it's all metal for your big bruxers and so forth. So I think that explains kind of how it works. And one other thing I'll mention about how it works, and we'll talk about when we use these more or less. I always ask the lab to put these hooks here. These hooks are for elastics, because on occasion, even though the jaw is protruded, the mouth might want to drop open. And if it drops open too far, it can negatively affect the airway at times. And I don't always know when that's going to be and when it isn't. So if I have them add these hooks, then you can have some elastics. And we just have a assortment of 6 or so different sizes and thickness of elastics that we can have the patient put there. And that'll help them encourage their mouth to stay shut and do more nasal breathing. And it could take this device from being not quite as effective to, wow, you put those elastics on it, it makes a huge difference. So I always get the hooks, even if we don't always use them.
That's a good point, Guy, because it's a whole lot easier just have them lab put them on than to try to send it back to the lab or get it in there and start grinding on stuff and putting acrylic on it and bending wire and all that other stuff. But I like to use these more, Guy, when I see a patient whose arch might be a little more narrow, their tongue appears a little bit bigger when I see scalloped tongues, when they can't breathe through their nose quite as well. Their nasal patency is a little bit down, and we all have a little bit of that because of the nasal cycling, and we roll from one side to the other, we get a little bit of that. But we don't need quite as much retention with this when we don't use elastics. I'll say that, Guy. When we put elastics, we need a little bit more, but we can move around a little bit. So sometimes people say, I have that claustrophobic feeling, or, a dentist made me one time and it wasn't adjustable and it locked me in. Well, we don't get that as much with this. You can make this, Guy, with very few teeth. I probably made this with, as little as 6, 7, 8 teeth in each arch. As we know, patients don't always come in with every other tooth missing. Usually it's kind of a few here and there kind of thing. But I like it in those instances, and I like it a little less, not always, but a little bit less, if somebody grinds really hard. And what I have learned over the years, Guy, is if somebody grinds really hard and I give them something flat in the back to grind on, they just might grind on it.
Uh-huh.
Now, that's not always true. Now, we can take these and we can put an anterior discluding element on them or something like that. So you always, as we say, Guy, you always got to use your brain. We're just giving you guidelines here. I think if you have your sample devices and you have the patient's models right there and you look at it and you do this stuff, I think most of you already know this. You just got to think it through.
Yeah, absolutely. I agree with everything you said. I'll even say that I've done this quite a few times with no upper teeth at all.
Right.
Completely edentulous, because it doesn't have to fit that tightly, because they could open. The elastics are harder you can't always use the elastics, but as you open, it doesn't dislodge it. So any device that allows your mouth to open, you can make it fit looser and it will still work. The ones that lock you in place, you know, they have to fit tighter. And I will say I'm with you on the Bruxers, but I mean, I'll back up for a slide for a second. If you've got a Bruxer, this one from I've learned from Whole U, with all the metal in there, I think it's the EF is what they call it. It really holds up well for the Bruxer. So when we talk about the different labs that we might use, you know, sometimes it depends on the patient, because I might choose the one with the metal from Whole U for that. But then if I've got one that someone's having a lot of work done on their mouth, we're going to talk about materials in a little bit that line these. There's different materials that go inside. We're going to get into that in a minute. I might send it to a lab like Dynaflex, who has what they call AccuFit, where you can reline it, not reline it, but just heat it up and change it as much as you want. So that's why you probably end up needing to work with more than one lab, but you can probably get it down to a few that you know and trust. And again, we'll be happy to help you with those type decisions. All right, so Herps, great for mouth opening, minimal teeth, all the things we just talked about. Well, why would we ever use a tap device? Well,
why, you ask? I'm sure Keith.
I'm asking the tap king here. So,
you know, the tap has gone through the tap 1, the tap 2, the tap T, the tap 3, the tap 3 Elite, and now we're on the Dream Tap. So the plate is now on the bottom. There's a bar on the top. It comes in a couple of different versions there. And I will say, Guy, that most of the research, not all of it, but most of the research out there that shows that dental devices treat moderate to severe sleep apnea better are done with taps. Now that's unfair to some of the other devices, because some of them don't have studies with severe devices. But I'm just here to tell you, I don't know why, but it is supported by a lot of the literature. It's something about kind of pulling on your jaw as opposed to pushing it from the side or something, kind of pulling it from the center. It just seems to work a little bit better. And but we've got some issues now with that Dream Tap, because we've got that device hook right there. So it adds a little bit more vertical component to it, you know, because think if I'm back, Guy, I'm a class 2 and then I have a deep bite. I might have to open 7, 8, 9 millimeters just to get to end. And then I got to add 8 or 9 millimeters of the material just for the tap there to get that. So again, you got to use your brain. You got to think about it. But
yeah, let me describe how this works, just to make sure. I think most of you probably know this, but some of you may not. There's a hook. There's 2 different versions, and I use both of them still. I use the Dream Tap, and I still use the Tap 3 that you can still get from certain labs. The new Dream Tap, the hook's on the bottom. Both of these have a key that you put right here on point. It's a hex wrench, and you turn the hex wrench. And depending on whether it's the Dream Tap where the hook's on the bottom, or the other iterations of the tap where the hook's on the top, you turn it either clockwise or counterclockwise. It's going to move that hook about 1/4 millimeter each 180-degree turn. And like Rich said, it pulls the jaw forward as it does that. So the Dream Tap, what I love about it is it does have more tongue room. It doesn't take up this tongue space because the hook's on the bottom and it attaches here in the front. One of the negatives is it can put a little more force on those front teeth because that fulcrum's kind of outside the arch, and so it's got to fit just a little bit tighter.
We've moved that point where it's pulling a little more anteriorly.
Yeah,
what I've found, Guy, is that a lot of times I'm in a position where I really want to make a tap because the patient has severe sleep apnea. They can breathe through their nose really well. You haven't got to this, but this is where we would use these devices more or less. But they got really short teeth, you know, from 6 to 11. Or maybe they have veneers that I just put on there, you know, as a dentist. You've got to grab onto those front teeth a little bit tighter now. And that can be a little bit of an issue.
That's what the Dream Tap, because the hook's outside the arch. And it's pulling down like a tray. If you're trying to loosen a tray that you just took an impression on, it'll pull it loose. It doesn't. If you've got good long teeth, no problems at all. It works great. So if you're going to be concerned about that, then you're going to go with one of the older versions of the tap where it has the hook on the top, like this one, and the bar on the bottom. The Tap 3, I think, is the one. This Tap 3 Elite, the Tap 3, they still will provide. There's a lot of different iterations, and they have different links, hooks here that you can do. But this one won't dislodge as readily because that hooks the fulcrum's inside. So we use these. So why would you use a tap? I think Rich hammered it home. I really believe for severe disease, if I want something to work, I know I've got one of the best chances in the world of this getting the apnea reduced the most with a tap. It's just the research is out there. My experience with it is, and I kind of gravitate towards a tap for severe disease. The shallow bite, like Rich talked about, if it's a deep bite, you don't want to do that because you're already going to have to open them up so much, as Rich already explained. You want to breathe through the nose. You know, if you can't breathe through your nose, me personally, when I wear this device, I'm a little claustrophobic because I can't breathe through my nose as well, and it just it can take a little bit harder to get used to. You know, fewer teeth. It really depends where they are. If the teeth are, you know, if you have great premolar to premolar and they're fantastic shape and just missing all the molars, then this may be the perfect device for the patient. Bruxers, I think this is a great device. It's like an NTI built right in to, you know, a deprogrammer or whatever you want to call it, built right in. So even if they brux, there's less to hit. They're hitting right in here in the front. And so they're further away from the fulcrum. They're putting less force. They just hold up well. And anybody that sleeps on their side cheeks, or we put on the other one, it's you know, a little scarier or something. All those, that metal. Some people are worried about, like the Herps with that. I don't find it to be a big issue usually. But on occasion, someone's really, really obese and got big cheeks, especially if they sleep on their side. Rich already mentioned the deep bites, large tongues. Not quite as much of a negative if you use the Dream Tap, but still a consideration. And if they can't breathe through their nose, it will work. I just think it takes a little bit longer for them to get used to it. And anybody, if you have a patient that's just sitting there in a chair going, oh, I tried the CPAP, I can't wear it, and I don't think I can wear one of these devices either. You know, they seem, you know, concerned. They're all tensed up. I'm going to go with, if it's a Medicare patient, I'm going to go with the Herps because I think it's, you know, if I don't care how well the tap works, if they don't wear it, it's as effective as a CPAP is if they don't wear it. And if we, you know, I think people have a little harder time getting used to these on occasion. Now, if they didn't know any better and you just hand it to them, they're going to get used to it. One thing I'll mention while I'm talking about that is I used to lay these out and say, okay, here's this one, here's this one. I basically gave this presentation to my patients. What I learned is it took about as long as this presentation does, number one. That's part of the 2.5, 3 hours it used to take. But also, they don't know how to make a decision. I mean, you don't go to your cardiologist and say, you know, we could do 2 or 3 bypass, and here's the materials we might use. What do you think? They make a decision, and they tell you what they think. So what I typically do is I decide which one I think is going to be the best for the patient. And we have a device selector we can show you that'll help you with that. And then I say, you know what? I've done my exam. Here's the one I think will work best for you, and here's the reason. I don't pull the other ones out of the box. And I show it to them, and I get them to agree with it. If they say, I have concern about something, I'll listen. Occasionally, I'll change my mind if they point out something that I hadn't understood about them, why they might not be able to wear it or what have you. So that's the way I do it. Again, the biggest negative of this one, I would say, is claustrophobia, and it's just not quite as easy to get used to, although we've made thousands of them. Most people do. Anything I missed on that, Rich?
No, that was good. And I mentioned the lip lickers, just, Guy, because I never knew how much I like to lick my lips until I made myself one of these, you know. So that could be, I like your point, Guy, about that patient that's sitting there going, man, I don't know, man. I mean, I don't like getting tied in and, you know, that kind of thing. I think that's a good point. I mean, you can get quite a bit of lateral movement, you know, with a Tap 3 Elite, and even with the Dream Tap, you can widen, you know, the acrylic on the front, and it can go a little bit like that. I don't like that as much because we'll have those patients that get on the side sleeper, Guy, the jaw will torque a little bit, you know, when you do that. The one thing I want to add, Guy, that with the tap, you can add the pads in the back to kind of tripod that thing, because occasionally we get people in a tap and they get sometimes they'll get, you know, unilateral jaw pain, and we'll put the bumps back there. So now I'm hitting back and front all at the same time. Those are little tips and tricks that you can look at doing that might help you.
Absolutely. And we have, through our training, we have all videos on how to add those stops, how to do edentulous patients, a lot of great videos that you can view, and we'll talk about how you can have access to those in just a little bit. The EMA is our third device we're going to talk about tonight. It is I would say, what I would say about the EMA, Rich, is that it's like the little fighter that comes out and beats up the bigger guy or something. It's underestimated. You look at this little piece of bisacryl or suck down material, whatever. Yeah, that's the right word. And it's really, but the thing works well and it holds up, better than you might imagine. So I think it's underestimated. How this works is, as Rich mentioned, it's just suck down trays that are made for the patient. We have different arms that we can put on here. There are 4 different rigidities and 9, I think it is, different lengths that they have. So the shorter, I'm going to go back here, the shorter the arm, so they usually put the little tabs in the canine and then in the molar regions. So if you put a shorter arm on there, obviously it's going to move the jaw more forward. I would since we only have an hour, I would just tell you, I live in the blue and yellow ones of these. The white ones are really flimsy and they stretch out pretty quickly. The clear ones work great, but they're really a bear to get on sometimes because they're really too thick. And I would say the vast majority of the time I use the blue is where I end up with the patient, because they're the right firmness, but the patient can still manage them. And these real short ones, you're not going to use a whole lot because they're really hard to get on. So I kind of use these. These are the millimeter length differences. And so you're going to have to kind of put it in and see where the jaw is. It's not quite as precise as turning a
screw or a jack screw or something like that. But I like the blue and the yellow, guy. We do a lot of that too. Oftentimes, which one we use? Whichever one we have the most of. We go, oh, that's the perfect one for you. We get a little tackle box, guy. I'm a fisherman, and one of the little clear things that has the little clips on it, and we order. These things don't cost that much money, so just have a good supply of those things on hand all the time. But I think the EMA, guy, is a lot like the Herps. What you say as far as when we use it more or when we might not use it as much. So if you can't breathe through your nose as well, I kind of have a nice little opening. The picture there that guy has, you can see most labs will make an EMA with little pads in the posterior area. And what that does is it bumps up the anterior opening just a little bit. You can kind of see them behind the bands there a little bit. And you can add to that. You can subtract from that a little bit if you need a little bit more opening. But again, if I can't breathe through my nose as well, now I've got a little more opening there. I put there not so crooked teeth, guy, because if you take a lower arch, for example, and you stick it on like a surveyor, most dentists got a surveyor around their office, and you just draw a little line for the height of contour. If you put 50 thousandths or something like that, with really crooked teeth, that line is so high that there's no plastic left on the teeth. So for really crooked teeth, you have to be careful because you can't grab too many underbites because it becomes very difficult to get off. The same reason for the deep bite, guy. If we got to add too much to that, we like the cost factor because this is one of the, is it the least expensive device out there, guy, or it's certainly one of the least expensive?
It certainly is. I mean, we get these from Keller, Dynaflex. A lot of labs have these, and typically it's one of the less expensive devices out there. I don't, when you say a surveyor, I think of the guy on the road out there. So I'm not really sure if I even have one of those in my office anymore. But what it means is it's going to either be too loose or too tight. If they're snaggletooth, you can't get it to go down. And if it gets down, then it's going to come loose. So that's probably the biggest challenge with this. You can make this, I think the way you said that, it may not have been clear. Deep bites, this can be really good if you don't do those stops. You can tell them to make the stops really little, And now, because this thing is so thin, it's about we're going to talk about the Narvel and the Panthera, which are basically are similar. This is just as thin as those. It's the thinnest, smallest device you can make for someone. And sometimes that's what people want. They just want the smallest thing they can put in their mouth that's going to hold their jaw forward. And I tell you, I don't know that we have it on here, but the people who really are aesthetics down at the bottom, I have people who care what these things look like. Maybe maybe they're dating, whatever the case is, and they don't want some big metal looking thing, and they don't mind putting this in at night. And I think that's a big one there. And the last I will mention, Class 2 in particular, those bands only come in so many lengths. So if you have someone who's really retrognathic, they have they've got a 10 millimeter overjet, you may put the longest band on you have in your office, and it still may be pulling them almost to the maximum of their protrusion. So it may be uncomfortable to them. So that's a problem.
The other thing, Guy, I'll do too, you mentioned the severe Class 2. Somebody that's end-to-end, or maybe even a little Class 3-ish, remember, I'm on that canine and the lower molar, and the more Class 3 I am, now I'm starting to pull straight up and down instead of, forward. So it's kind of the extremes, real severe Class 2 or Class 3, you steer away from it a little bit.
And I would say the last thing is this, a real big bruxer. These things, I will say, hold up way better than I ever thought when I did the first one. They do, especially if you'll train your patient not to pull those don't pull on the little tabs where the rubber bands hit. You want to tell them to grab the acrylic behind that and pull straight down. They'll break the little knobs, these little knobs where the
little buttons.
The buttons, that's the word I was looking for. If they don't pull on those, they pull behind it and then the lower in front of it to dislodge this. They will hold up way better than you ever thought, but they're not going to hold up as well as a Herps or a tap in some situations. If somebody's really beating this thing up, it's not going to hold up quite as well. But
yeah, and when those, what do you do when those buttons come off, Guy?
I mean, you can re-adhere them pretty easily, but you can send it back to the lab. Depends on how much time I have.
Okay.
Depends on my assistant that's there too. That you can repair it right there.
Yeah, we run right in the lab, man. We just roughen it up a little bit with a little acrylic, and then put them in the pressure pot for a few minutes. So you can move the buttons as well. Guy, if you got a severe Class 2, you can make them a little closer. That is a lot easier than somebody who's a Class 3 where you have to move them farther apart. Because if I have to take that lower button and move it back further, that's very hard to do because most second molars don't have very much height to them, top to bottom. So I'm running out of room back there to put a button. I might have to add to the pad. If I take the anterior button on the top, the canine, and I move it around that arch, it really changes how that thing works. I put a whole lot more pressure on those front teeth. So you got to be careful with the lower. Don't move it back too far. With the upper button, don't move it too far forward.
And if you don't do this on a real Class 2 or real Class 3, you won't have that issue. Right. So I mean, that's it. You get a severe either one of those, you won't have that issue. So one thing I'll mention too, while you're saying all that, is we're not going to really talk about impressions today, but you want to impress more than just the teeth. I just had a recent one where we didn't get the big tori down here, and so that rubber band was digging into the tori, exostosis rather, that was on the buccal right below the molar. So you've got to remember, some of these pieces of these devices go up above the teeth, and if there's a big piece of bone, exostosis sticking out, and you don't capture that in your impression, well, the lab won't know it's there, and you may pinch that with your device once you have it made. So the dorsal, we got 2 more left, and then we're going to talk about what you do after you deliver these and what materials go in. So we better get moving. The dorsal is, I think, one of my favorites. It's one I particularly wear myself most nights. A lot of labs make these. That we, again, whole U, we've got, I think, Dynaflex is here in the middle, Somnomed over here. You can even put chips in these as well. How these work, there is a wing and then there's an adjustment. The adjustment is typically about 1/10 of a millimeter. You put a key in here and you twist this way, in this case inferiorly. It's going to move that piece of acrylic, and that's going to move that that wing forward. With the whole U Respire, it works the same way. You have a key you put in the bottom, and it's actually going to move the wing itself, and the abutment and the back stays right there. And so the pros and cons of this one, we'll talk about where you use it more or less, but it's similar again to the Herps. I think the EMA is somewhere kind of in between, but this is similar to the Herps because it allows your mouth to open. It does a lot of the things we already said for the Herps are the same here. I would say the only difference is because of that friction between the wing and that stopper, it tends to not encourage the mouth opening quite as readily, and especially depending on what angle they put that wing. If they put it, angled back a little bit, it even makes it harder. So the mouth doesn't drop open quite as readily as it does with the Herps. But even being, I would put either hooks. If you use the one from National Dentech, they actually just put little grooves in the acrylic here so that we can add elastics to. So you want to have a way to add elastics to these as well, but we're going to less likely need to use the elastics with a dorsal design. So a lot of the same positives. I would say that all in all, it's probably a little less intimidating, a little less material on the sides than a Herps, but we can use it with all the same patients that have reduced retention, reduced number of teeth, and we can't make it fit as tight. I've done many of these on completely edentulous upper patients, and if you want to see videos on that, we can point you towards that. And I think this one's right up there with the EMA as far as patients saying they, oh, that one looks, they're real picky, and they're gonna like the way this one looks. I would say the limitation to this, it doesn't hold up as well in some cases as a Herps, or certainly as much as a tap, if someone's going to really grind a lot. You can have the acrylic break in various areas, typically in the back. You can do the new whole U design actually has two wings, has a wing on the top and bottom, and it minimizes sideways torquing. If you do that with the metal, they do, I think they rival some of the others as far as rigidity goes. But to me, mouth breathers, nasal breathers, you can't breathe through your nose, minimal teeth. I guess that's why I like this device, because I have nasal breathing problems, and this allows me to open my mouth, but doesn't encourage me to open as much as the Herps does. Anything I missed on that, Rich?
Can I add one thing about that thing breaking, Guy? Because just, like Guy said, we're not real smart. We just been doing this so dang long. We made all the mistakes at least once. So that put your cursor, Guy, on that. Yeah, right there. So we had two people in one day, Guy. They were adjusting their device the wrong way. So instead of moving that forward, they were moving it back. And when you get to 0, it doesn't want to move back. And they kept tugging on it, and they broke that whole back part of that off. But that's why, because they moved it, too far back. So what we do a lot of times now is we preset that forward about 5 clicks, and we don't have them adjust more than that, without calling us or something like that. But I think you covered that well, Guy. The thing I want to emphasize even more is that when retention is really a problem, this is where the dorsal can really shine, number one. Number two, it is very comfortable. You heard Guy say, man, this is the one I wear a lot of nights. Guy and I have the advantage of doing this kind of stuff and teaching people. So labs make us dental devices when they come out, So we have a bunch of these things laying around. So we get to test out a lot of these things. And, it's different for different people, right, Guy? Not everybody likes the exact same one. But hopefully we're giving you guys some ideas about when you might lean a little more towards this device or a little bit more towards a different one.
Yeah, and this one I would say, if you have that tense patient that we're talking about, this is my favorite device. Now, if they're Medicare, I'm going to make them a Herps, because I have to. But if not, I think this one's slightly more comfortable than the Herps, a little less intimidating without the metal. And the other big advantage of this one, which we haven't mentioned, which I think is worth mentioning, is this is 2 pieces. So if someone's claustrophobic or they've got a little bitty opening, they can go ahead and put the top in, and then they can put the bottom in, or vice versa, depending on which iteration they have. And so you don't have to get the whole thing in at one time, and that can really make a difference for gaggers, people that are just nervous about the whole procedure. And I think that's something to certainly make note of. Again, wouldn't say they break a lot, but they can. And Rich pointed out that's probably the most common area they break. That being said, I do these all the time, and
yes, we do. We do a lot of dorsals. We do.
Yes, we typically don't have a problem with it. Looks like we have that slide in there twice for some reason. Anyway, I guess I just noticed that. So I think that's pretty much it for the dorsal. And then, Rich, you said you've done quite a few narvals recently, or Panthera. So let me just. There are two companies that make a similar device. So you can research them both and decide who you want to use for them. They're a 3D printed device. And what's the material? I've got it on another slide coming. It's like a nylon. I don't know.
Apparently it's top secret, Guy. They won't tell me. Medical grade polyamide nylon. It's some pretty cool stuff. I can tell you. You can take this thing and you can bend it and you can twist it. And I haven't tested it yet, Guy, but I'll bet I could put it in the driveway and run over it with my truck and it probably wouldn't break it. So they cost too much, to do that too. But I love these things. We get to use them a lot. There's a number of different designs. It depends on how much teeth you want to cover and what you want to do. And you mentioned the EMA, Guy, as being a very thin device. Yeah. So the EMA is the one with the rubber bands on the side, okay, the yellow, blue, white, clear rubber bands. You can make that out of 2.0 or 2.5 BioAcryl, but even the 2.0 is thicker than this is. So this becomes very thin, So and it's also a hinge device similar to the Herps, but not exactly the same. And do you have a slide in there, Guy, about how to adjust that thing?
No, that's what I thought I did. Sorry, I don't. But so
talk about how to do that real quick.
Yeah, so we'll talk about materials in a minute. I think that's where we can talk about adjusting. But these just have different arms, similar to the EMA, but these come in 0.5 millimeter increments. They don't stretch; they're not stretchy at all. And this has a key on it. And I guess we don't have it. Well, hold on. I meant to point and I hit the wrong button. You can see it back here a little bit. There's just a lock and key. You just get it to 90 degrees, and you just pop them on and off. So it's pretty easy for the patients to do. There's quite a bit of adjustments on it. These are made, again, a CAD cam. You've got to have really good impressions, and if you do, they're going to fit the vast majority of the time. The one thing I will mention when we're talking about design and when we talk about materials, we can talk about how you adjust these with a burr or what have you. But this is the original design. There was no engagement of the anterior teeth. Fits comfortably, it's great, except for you can get tooth movement in some patients up here because there's no engagement of the anterior teeth. Depending on which lab you get it from, now you can get this with full coverage over the anterior teeth, so it actually locks around all the anterior teeth, or it'll just go over to a third or so of the anterior teeth. I would recommend always doing at least a third or so over the anterior teeth, unless the anterior teeth has some compromises or something you're wanting to avoid putting any pressure at all on them. To avoid that tooth movement that we have seen on some cases. Most of the time, you do not need elastics with this one because the way this is designed, when you push back, it wants to make the mouth close. It's hard to describe here on the webinar, but there are rare occasions where they help. And to put elastics, you just cut little grooves in here because this material is so hard that you can put the elastics on there. And I would say the claim to fame to this one is it's the sturdiest one out there. It doesn't look sturdy at all. Like Rich says, it's this flimsy thing, but you cannot break these things. I have a friend of mine, he's a periodontist. He's literally broken all 4 of these other devices we've talked about. And he's still wearing one of these to this date that he has not broken. He is just brutal on these things and has destroyed his, and it's held up. So I would say that's what I would use it for. The drawbacks are there's not much adjustability on it, which we're going to talk about with materials now. So I guess let's get to materials so we can get finished on time here, Rich. When we're talking about materials, we're going to talk about the other 4 devices, and then we'll talk about the Narval Panthera because it's kind of in its own class. Most of the other devices, they'll either have metal and acrylic or just acrylic, but inside, the part that touches the teeth is typically one of 3 materials for the most part. One, it can be all acrylic inside there, and I think that's the advantage to that, is you all know as dentists how to deal with this. You've got acrylic in your office. You can salt and pepper things if you need to add to it. Sometimes we have these ball clasps on here that we can use to adjust and tighten. Those can also move teeth if you don't wrap the distal tooth back here to make sure. But acrylic, I think the big advantage to it is it can be thinner because you don't have a liner in there, and we're used to using it, and we can reline it. Anything on acrylic, Rich?
It's awful easy to make looser or tighter. We just grind on it, or we go back in the lab, and you can't do that with a flex material. This one that we're talking about, because nothing will bond to it. But it is a little bit more comfortable, right, Guy? Because you said it absorbs a little bit of that shock. It'll actually flex around the undercuts a little bit, so I can have something that doesn't. I don't have to push on. You feel like I'm getting a workout, just to get it in or get it out, because that stuff does flex a little bit and it goes around there. But it doesn't quite last as long. What we tell everybody is, if you see that start to separate, you got to call us immediately, because a lot of times we'll just take a scalpel and we'll carve off a little tiny corner or something, because like most things in dentistry, when two things don't line up, what gets in there? Saliva, bacteria, all that other stuff, and it'll start to delaminate. So you do have to make the devices just slightly more thick when you do this, and they will discolor over time. But overall, I think it's a good lining, Guy, and I think it's very comfortable.
Yeah, and if you've got undercuts, it'll go around them and get in them. And this, so you got that tense patient again. You do a dorsal or a Herps with this flex material, they're going to be the most comfortable. They're going to feel a little cushioning when they put it in and out. It's not going to snap on and off quite as hard as with acrylic. So, and different labs call this different materials. Some of them call it flex. Some of it call it comfort fit. There are different words for each one out there. But they basically all make a dual laminate. It's a rubbery material on the inside. And I think the biggest thing there is it's a little more comfortable. And then the thermocryl is something that, boy, I was resistant to, but Rich finally convinced me to start doing more of this. And it's a material that Airway Management, I think, developed. And I use it in pretty much 100% of my tap devices, because the tap has to fit pretty tight and I can adjust it. But I use it in a lot of other devices too, as well. And Rich, you even did a video once, and we don't have time to show it tonight, on the eighth wonder of the world, thermocryl, right?
And my wife walked by my boat the other day, and a little piece of my trolling motor. She said, "Is that stuff you use at the office?" It's holding half my boat together. So it is a thermoplastic. You heat it up, and it gets real clear. And then it's kind of like sticky Play-Doh. Yeah. So the patient rinses their mouth with some water, so it's just a little wet. I do this one at a time. So in this particular case, we've got a Dynaflex dorsal device that has thermocryl in it. And then we're going to heat it up, and we're going to push on it real hard. We count to about 10, and we tease it off just a tiny little bit. Push on it again, count to about 20, tease it off just a tiny little bit. Don't take a phone call when you stick these things in, because they can lock in undercuts and things like that. So it's got a little bit of a learning curve, but so you got to be careful with it. And you need a real sharp scalpel to trim out the little pieces, of that kind of stuff. So, but the reason I like it, guys, I can always make it fit.
Always fits. If you don't get the greatest impression because the patient's gagging, if the patient's coming from a long way off and I want to make sure this thing's going to fit, or if they're going to have a lot of dental work done. And,
exactly.
If they look in their mouth, they've got all these amalgams, and they're going to be problems, then I know I can just heat this thing up. Good example, my mother's significant other just was getting a crown. My mom's like, well, his device fit. Well, I knew that he had some shaky teeth in there. He's 89 years old. And he's getting a crown this week, and I'll just be able to refit that right back for him. So that's the big advantage to the AccuFit, or some labs call it, or thermocryl, and we use that quite often. I will say the only disadvantage to it, or one of the ones that you should note, is it can discolor quite dramatically over the years, and somebody who's really germaphobe, you can clean it and disinfect it and make it, perfectly fine to go in the mouth, but it can get some really funky colors, and some patients kind of freak out about that because it can absorb some of whatever the patient has in their mouth, or whatever more. So here's the material that the narval or the Panthera is made out of. I think we talked about it a little bit, but one thing I'll mention about it not only is it the strongest, it's one of the thinnest, which is great, but you can't add to it. It's not acrylic. And so these things fit great, but if you want to adjust them, if you adjust them a little bit, you don't have much room to adjust them. They're very thin. You'll go right through that material. So they make these fit precisely, and you seldom have to adjust them. But let's say they go get a crown, and that crown's bigger than the tooth was before because it was worn and what have you. You may have to make a whole new arch because you're going to have a hard time getting that to fit around that. You can't take some quick cure acrylic and add to it. So one of the drawbacks of this device is if I look in their patient's mouth and I feel that there's a decent chance they're going to need dental work in the next year or two, I'm going to do something I can use hard acrylic with or thermacryl. This may not be the device for that. You've got to have great impressions with this because they dial those in with undercuts. And if you can't fudge as much as you can with acrylic, so you've got to get really precise impressions of all the undercuts. And if you do, boy, these things hold up and fit great. So anything on that, Rich? We'll move on here as far as the material.
No, it is a little bit harder to make tighter. You know, everybody, I think my experience, Guy, in reading through these questions is, a lot of us as dentists, we get comfortable with a material. And that's okay. There's nothing wrong with that. That means it works in my hands.
Right.
I think you are a better dental sleep practitioner if you feel that way with all of these materials.
Yep.
Doesn't that make sense? So don't be scared about that. There's nothing wrong with being an acrylic guy and you love acrylic, or EMA and I love it. You know, I mean, there's a lot of different devices out there. There aren't a whole lot of materials. So I would encourage you to learn all you can about all of the materials to figure out where each one has its place where it might work just a little bit better. I think that's what helps make us, Guy, better dental sleep practitioners is we made a lot of these mistakes. So we know maybe in this particular case, I might use this device and I might use this material and I might design it a particular way. I think it just increases our chance of success.
And one thing we can do if you're care to learn a little more, we have what's called a device selector. And I think it helps when you're first doing this. You look at all the things that we teach you, comfort, bruxism, tongue, all the things we've talked about tonight. And you can just slide, if the patient's a big bruxer, you move it over here to more bruxing, big tongue, small tongue. And then you hit sort devices, and it'll put the ones up near the top that are probably the ones you should look at first. And it's kind of a great way to learn as you go through this. You're going to have to use your brain no matter what we teach you. There's going to be situations that you have to just kind of think about. But don't be afraid to do these. What Rich talked about, when I first met Rich, I was not doing as much as he was of dental sleep. And his advice to me was great. He's like, just go out and make 5 of each of these. Make one on yourself, make 5 on this, make then 5 on the next, and you'll learn which ones you like better. Don't be afraid to make it because they all work. Most likely, whatever device you use is most likely going to work. So I'm going to just
what I think a big part of that, Guy, I want to add to that is confidence.
Yes.
When that patient looks at me and I say, look, this is the device you need to use, and this is why. This is the material I would use. Here's my rationale for thinking that. It is the best way to go. That has a lot to do with our success as well, and just our confidence. Absolutely.
And we can talk about what you do once you give them the device and how you reposition their jaw and the steps you go through. And we're going to go through some of that at the next webinar, rather. And so I want to make sure we respect your time and end on time here today, because I think we spent a little more time on the devices, but that's what the webinar was about. So I feel like we hopefully gave you some really good information. If you would like to learn more about actually doing these steps in your office, I mean, we can help you get to the point where you can do this in less than an hour. I mean, even if you do one device, every other week. What is that? My camera's hiding it there, but there's 24 a year, you're adding 40-something thousand to your production. If you do one a week, you'd be adding close to six figures. And these are very conservative, including your taking out the money for your lab and including paying someone to help you with insurance billing. So, I mean, where can you do that to do one device a week and add six figures to your practice? And, people ask what we do. We help you we've helped hundreds of offices go from not knowing anything about dental sleep to now they're doing it in their office. And what we've done, I think, better over the last few years, Rich, that I think you and I are most proud of, is we're able to do this in around 90 days. Most people that come on board are getting insurance checks or getting paid for devices within the first 90 days if they'll use the systems that we have. And if you want to know more about how we can do that, just type in consultation and we'll talk to you about it. And a lot of times I think people, when they type in consult, ask how much that costs. We can get you to there for under $1,000. So our fees to get you to help train you, show you, answer the questions, give you resources to do this, and literally talk to our trainers in order to get these systems in your practice are less than $1,000 to get you to making your device in the first 90 days. And you're going to make more than $1,000 on that device. So really, if you're interested in it, we're not high pressure people. I think put in consultation. Someone will first start with answering your questions, seeing what we can do to further help you. If you want something for free, we'll help you with this magazine. If you've not already subscribed, we'll put this out every other month. I think one just recently came out that we did. I always do a video because I'm much better at that than Rich is really good at writing. He writes an article most of the time. We have a lot of guest people that contribute, but there's really good, valuable information. So just go to Dental Sleep Insider, and you can look at all the back issues and videos. I think one of the things that came up tonight was doing on a dentist patient. There's videos and some of the past issues about that. Or anything else you want to say about the Insider, Rich?
Man, it's good stuff. We put maybe 20 issues together now, and we probably get 30. Okay, there you go. So it's just a lot of good practical information. Again, how do you bill insurance? How do you do this? How do you make a device tighter? Guy had something in there where he's cutting off a part of a Herps and he's doing this and that, and it's just a lot of really good stuff in there, and it's free. So we would certainly hope that you will take advantage of that, and we hope to build some kind of a relationship with all dentists out there, because that is our mission. We are trying to help dentists do this, and we don't feel like anybody else out there does it as well.
Yeah, and we talked earlier today about if you want to be successful, you need a system for screening, testing, treating, and billing. And that's what we do at DS3. We help through education, coaching, support. We have a cloud-based software that makes that even easier. And again, if you want to know more, just type in consultation. We will show you how to do this. And again, you can, if you'll utilize what we present to you, and we'll actually be on the kind of balance between being there for you and even being annoying and persistent, trying to be like a personal trainer, getting you to do this. And for under $1,000, you can be up and running and doing these systems. And we love you coming to our courses too. I know we mentioned those, but for those of you who can't, we can help you, from the comfort of your own offices. I think a lot of people will start with the training through GoToMeetings in our system, and then they really get involved in this, and they want to come to the course, and they even get more out of it that way too. But we do hands-on courses is what we're really focusing on now, that where some of the things that you're going to ask, you don't know what to ask until you've done a few of these devices, and you actually put the devices in your own mouth, and you actually wear a home sleep test yourself. I mean, I really don't think anybody can tell you really how that feels, or especially if you look at the data and you see we have some great home sleep testing partners that we work with to provide those. It really is a great experience, the more hands-on that we do. Again, this is our next one that's coming up in February 27th, and I think we're getting to a lot of these questions, Rich. I know you're much better at answering those than I am. I'm going to go ahead and put our contact information back up there, and let's see, do we have other questions?
I think we've covered it pretty good. I was kind of directing some of the conversation guy to answer a lot of those questions too, for people that maybe don't see the questions or they're just listening to the audio as well. So, and we record these things as well, and we archive them on our YouTube channel and through DS3. So we certainly hope you guys got something out of this. Hopefully you've got some kind of way to record the Olympics so you didn't miss anything important tonight. But again, thank you guys for joining us tonight. Thank you, Guy, for putting that together. That looked awesome.
Yeah, well, thanks everyone. We'll I know a lot of you. I see we are some few names I recognize. I'm looking forward to seeing those of you in Clearwater on Thursday night, Friday, Saturday. It's going to be a fantastic meeting. I'm really excited about it, and then we look forward to also talking about the exciting subject of documentation next time. We promise to keep you on and entertained enough to get through it. It's important, and I think what you'll find is we'll make it a lot more straightforward. We'll take kind of a messy way of doing things with lots of papers everywhere and a condensed system for doing this in your practice. So thank you all for taking the time. I think we got to all the questions, Rich, it looks like.
Yeah.
So
looks good. Well, thanks, guys.
Fair enough. All right, have a good night, everyone. All righty, bye-bye.